Good evening, ladies and gentlemen, my distinguished panelists, and all the viewers. I'm Dr. Nishant Sharma. Welcome back to another series of virtual discussions on arthritis in India, a nationwide dialogue. This series is a joint initiative by Voice of Healthcare and Pfizer, where we will be talking about the different spaces of arthritis and its care and delivery in India. We will be discussing in depth about understanding arthritis, its management strategies. We'll talk about the different prevalences of the different types of arthritis, about public health initiatives, and some measures of prevention. So, without further ado, I'd like to welcome my expert panelists who have joined with us today. I have with me Dr. P. Prabhakar Rajamani, Associate Clinical Director and Head of Department of Orthopaedics and Joint Replacement at Care Hospital, Nampally, Hyderabad. Good evening, Doctor. Thank you for joining us. Yes. We have with us Dr. Jagan Mohan Reddy, Senior Consultant Orthopedic Surgeon, Care Hospital, Gachibowli, Hyderabad. Thank you, Dr. Jagan, for joining. And we'll also have Dr. Kunda Sridhar, orthopedic surgeon at Kunda Hospital, Vijayawada, who will be joining us shortly. So, without further ado, let's start this conversation with Dr. Jagan. Dr.
Yes.
Jagan, let's start and set a theme of this conversation. So, let's start understanding about arthritis. To all our viewers who have joined, my question to you will be provide an overview of what is arthritis and what are the different forms of arthritis that are prevalent in India. Over to you,
Yeah.
Dr. Jagan.
Yeah. So thank you. Thanks once again to the Pfizer team for inviting me as a guest faculty. Arthritis is one of the major disabling disease in the public, especially if the age grows. If you become elderly, it is one of the most disabling problem. As you all know that life is moment, moment is life. This arthritis will limit the mobility. So you raised a nice question. The first question, what you asking is, what is arthritis? Arthritis is the inflammation of the joint, wear and tear of the joint. In a normal word, is a simple thing is called wear and tear of any joint is called arthritis. Like knee arthritis means damage of the cartilage of the knee joint. Hip arthritis, knee arthritis, ankle, shoulder, wrist, any joint may undergo damage over a period of time. That is called arthritis. Itis is an inflammation of the joint, damage of the joint is called arthritis.
Hmm.
So, ask second question, what are the types of arthritis? You will say, you said.
Right,
Yes.
right.
The basically arthritis got two types. The first one is a primary arthritis, second one is a secondary arthritis. Primary arthritis means there is no exact cause, but it is mainly age related. As age advances, as progresses, normally the wear and tear will occur. For example, you will have hair loss, gray hair, cataract, prostrate. Same like that, joints will damage because of repeated use over a period of time. That is called primary arthritis. Usually, the primary arthritis seen in the elderly people. The other spectrum is called secondary arthritis. Secondary means there should be some underlying cause. For example, trauma. If you have a football injury, cricket injury, or road traffic accident, that causes the damage to that particular joint. That will leads to the arthritis. That is called secondary arthritis. Or there are some inflammatory conditions like rheumatoid arthritis, ankylosing spondylitis, seronegative arthritis, psoriatic arthritis, Sjogren syndrome. Like that, there are plenty of inflammatory arthritis that will also cause the secondary arthritis damage to that. Basically, this secondary arthritis can be seen at any age. Usually, we will see at younger age groups in secondary arthritis. These are the main two types of arthritis.
Thank you. Thank you, Dr. Jagan, for setting the introductory theme for this conversation. Moving over, Dr. Prabhakar, my next question will be for you. What are some common signs and symptoms of arthritis that you see in your clinical day to day practice? A patient walking in, what do they present with? And secondly, please talk about some key risk factors that are associated with the condition of arthritis. Over to you, Dr. Prabhakar. Sir, you're inaudible for some reason. Hmm.
Sir,
Let
unmute it, unmute the camera. No,
Hold
still
on.
we can't hear, sir.
Sir, you might as well maybe drop and reconnect once because it appears that there is some voice issue from your side. Meanwhile,
Yes.
we'll have this question put to Dr. Jagan,
Yes, sir.
and you can circle back. Yeah. So, Dr. Jagan, the same question to you. Some
Okay.
common signs and symptoms.
Yeah. Arthritis, the first symptom is the pain. Pain, pain, pain. Patient will have pain at the initial part. Patient will have pain after a period of activity. As the disease progresses, the pain will increase. Pain will, even at rest will be there. So the first symptom is the pain. Second symptom is the restriction of movements. May have a deformity, difficulty in doing their activity of daily living, like going up and down the stairs, going into the car and coming out, going into the shower and coming out, getting up, sitting in the ground for puja and other things. They have the limitation of their activity of daily living. So the pain, restriction of range of movements. For example, if you take a knee arthritis, the patient will complain of knee pain initially after a period of walking. But as the disease progresses, the patient will have pain even for few steps. Even at rest, they may have pain. If sometimes they have pain at the night. And deformity, the knee joint becomes bent, and restriction of movements. They can't straighten it fully, they can't bend it fully, they can't easily get up from the chair or get up from the cot. That is a restriction of the activity of daily living. And limitation of walking distance. They can't walk so far. And they have to consume, they will ask for painkillers to get away from that pain. These are the main symptoms.
Right, right. Dr. Prabhakar, can you speak something? Let's check if your audio is working. Unfortunately, you're still not audible, sir. Are you
Sir,
connected through a laptop or your? Maybe you can try through your phone, sir. If your
yeah,
laptop is
change the device. Change the
uh,
device.
maybe change the device. Really unfortunate, Dr.
Different
Prabhakar.
laptop or the mobile.
Right, right. I hope you're using Google Chrome, Dr. Prabhakar, as the browser. Okay. Please try while we keep the conversation on with Dr. Jagan. So,
Yes,
Dr. Jagan, you just gave us about some common signs and symptoms. Let's talk about some key risk factors that are associated with arthritis, please.
yes. One for primary arthritis is the age is the risk factor for primary arthritis. As you go older and older, the arthritis becomes severe and severe. That is the first risk factor. The first risk factor is the age. The second risk factor is the genetic factors. Third one is obesity. Obesity is the major things. Obesity means overweight, high BMI. They are more prone for arthritis.
I see.
Some inflammatory conditions like rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, they are the risk factors. Family history. Trauma means repeated activities like a high contact sports like football, rugby, where they have a lot of interaction, very high risk of damage to the joints. They are the risk factors.
Okay.
Obesity, these are the things. And some uric acid conditions, some conditions like uric acid, if the uric acid is high, there is a risk of arthritis. So these are the risk factors.
Thank you.
Age, women is a more risk factor, obesity, trauma, inflammatory conditions, genetic factors, they all play a major role.
Right. Thank you, Dr. Jagan. So, being a clinician of orthopedic practice, how do you create a diagnosis for
Yes,
arthritis? What are the different steps that you deploy while you're making a diagnosis for someone who has presented to you with the symptoms of arthritis? Please.
yes. If the patient comes to us, patient comes, walks into our clinic with the pain, they won't come that I got an arthritis. They will
Hmm.
come that I got a hip pain, I got a shoulder pain, I got a knee pain, I got an ankle pain, or elbow pain, wrist pain. They will come with that. So we, as a clinician, we will carefully will take the history, when it has started, how it has started, what are the aggravating factors, what are the relieving factors, whether is there any diurnal variation, more in the daytime, at the end of the day you have more pain, you have any night pain. Then we will carefully examine the joint. What is, suppose if it's a knee arthritis, how is the knee? Is there any tender spot? Any,
Mhm.
how is the range of movements? Any deformity? And patient is using any walking aids. How is that? First, clinical examination, history, then we will ask for specific investigations. Mostly, we will get away with X-ray. If X-ray shows arthritis, how severe is the arthritis, we can get away from the X-ray. And depends upon the possible differential diagnosis, we will ask some blood tests. What are the blood tests? To check is there any inflammatory conditions. For rheumatoid, we have specific tests. For ankylosing spondylitis, we have specific tests. Depend upon that, we will ask for a arthritic profile blood test. Mostly, we
Okay.
can get away the diagnosis by examination, by history, by simple plain X-ray. We can get 90%. We can get the diagnosis. In other supporting, we will do a blood test, sir. With this, we can come to the reasonable conclusion about the arthritis, what type of arthritis, what is the grade of arthritis. We can come. We can come to the conclusion.
Right, right. So, while that you have mentioned about grades of arthritis, I'd like you to elaborate that for all our viewers about how arthritis progresses
Yes.
from let's say the early stages of arthritis to a grade 4 arthritis. Please.
Yes, correct. It is a grade 1, grade 2, grade 3, grade 4. These are the radiological stages of arthritis. Radiological means it is an X-ray diagnosis. If we take an X-ray only, we can say that it's a grade 1, grade 2, or grade 3, or grade 4. So how do you know whether it is depends upon the patient symptoms? By X-ray only we can say 1, 2, 3, 4. But clinically also we can say that it's a early arthritis or mid-range arthritis or severe arthritis based on his symptoms like severe deformity, severe restriction of activities, crepitus, lot of noise is coming while moving the knee joint. That means clinically it is a severe arthritis. But
Okay.
based on the joint space, based on the sclerosis, based on the extra bone that is called osteophyte formation, we will grade it as grade 1 to grade 4. Grade 1 is mild narrowing of the joint space, grade 2 is more, grade 3 is obliteration, grade 4 is complete obliteration of the joint space. The top bone and bottom bone are touching together. That is a thigh bone, that is a femur, is touching the tibia. There is no joint space. Complete obliteration of the joint space is grade 4 arthritis. That
Right.
will be diagnosed only by the clinician, or orthopedic surgeon, or a radiologist will diagnose.
Right. Thank you, Dr. Jagan. Dr. Prabhakar, let's check
Yeah,
your audio
can I?
now.
Oh,
Am I
yes,
audible
sir.
now?
Thank you.
Yes,
My
yes.
apologies, some unforeseen technical
Great.
glitch. Thank you,
No,
Dr.
no
Jagan,
problem.
for holding the fort for so long.
Yes, yes, Dr.
Yes, Dr.
Prabhakar. So we were just discussing with Dr. Jagan about what arthritis is, some common types of arthritis. He has
Yeah,
very elaborately mentioned about how different stages of arthritis progress and how a diagnosis is made. So I'll start
yes,
this conversation with you by talking about the importance of early diagnosis that
right.
we have in arthritis and the overall treatment outcome for individuals with arthritis. How does early diagnosis impact that?
Yeah, that's an excellent question, Dr. Nishant. See, uh, Dr. Jagan has already specified with regards to what are the types of arthritis which come into the picture. If you're looking at a primarily situation wherein there is a kind of a secondary arthritis which is expected, for example, a person who's probably has had a fracture, perhaps not got the adequate treatment or was treated improperly by perhaps somebody who was not so well qualified, what actually happens is we do anticipate that the assuming that it was the knee joint, there is some amount of incongruity as far as the articular surface is concerned. Now we do know that this is something which is going to predispose to early arthritis, given the fact that this gentleman is going to be living a moderately active life as per his age or as per his requirement or perhaps his occupation. So what we tell them in terms of these kind of situations is that you do have a problem. The joint surface is perhaps not as smooth or not as congruous as it should be. So some amount of lifestyle modifications are in order. Now this is primarily done to ensure that the damaged surface tends to last for as long as it possibly can. Before we are looking at a situation wherein the joint surface gives way, and as Dr. Jagan mentioned, it gives rise to a degree of deformity, a degree of pain, which is restricting his normal activity of daily living and hampering his day to day functioning. When that stage arrives, if and when that does happen, it can be diagnosed with various modalities. Commonly, what we do tend to do is a clinical examination when a patient comes to the OPD. There are various scoring systems by which we tend to assess the requirement in terms of function and also the hampering of the function firstly. Along with that, some amount of other investigations, basic being an X-ray, and perhaps we may also go in for higher investigations in the form of an MRI if so determined. When we look
Mhm.
at the picture in toto, then we are in a position to kind of give them some kind of a solution. However, we do tell them that if you do tend to avoid these activities, for example, if there is a secondary arthritis anticipated, we tell them that you can carry on with normal activities. However, try to restrict yourself from situations where you may predispose to early wear, like maybe perhaps jogging, hiking, excessively than what is normally required for his day-to-day activities. So pulling back on some aspects may perhaps just prolong the life of the already damaged or decompensated cartilage. Apart from this, other modalities in terms of physical therapy, wherein strengthening of these muscles which tend to support the joints around, and also the other factors in terms of lifestyle modifications, for example, to avoid squatting, sitting cross-legged, any of those activities which put enormous amount of pressure across the knee joints perhaps can be avoided. Having said this, this is with regards to secondary arthritis when it is predisposing and secondarily to some kind of a trauma event. But in cases where there is rheumatoid arthritis, where we know that the gentleman or the lady concerned has already been diagnosed, is perhaps seropositive, you know that this is the situation. There is, of course, the importance of physical therapy. There is the importance of the exercises, lifestyle modifications. But in today's day and age, we have various other options in terms of disease modifying drugs. We have biologics which have come over. Now, these are aimed at delaying the progression of the disease as far as is possible. So this also contributes significantly to improving the quality of life and also tends to prolong the overall the health of the joint and make sure that we can delay it for a period of time which perhaps may be productive enough in terms of quality of life. And of course, the surgical option always remains on table. So that's probably our ace in the whole, and that's something which we would like to keep for a stage when it really becomes unbearable for the person to even carry on with basic functions around the house or so on and so forth. So that's where
Right, right.
we tend to classify these individuals.
Thank you. Thank you, Dr. Prabhakar, for very elaborately mentioned. Dr. Jagan, my next question will be for the both of you moving over to the next topic, like Dr. Prabhakar very well mentioned about the different management strategies. So,
Yes.
Dr. Jagan, let's talk about some effective strategies for managing arthritis in all the senses, be it medical, be it surgical, be it lifestyle approach changes. Please comment on a few, and we'll have Dr. Prabhakar continue
Yes.
to that, please.
It is a arthritis. It is a disease. So as you all know that prevention is better than cure. So it is called primordial prevention. You start from the preventive method to the advanced treatment of the arthritis. Preventive method is starts from the day one. So how to prevent the arthritis? You have to give an education to the patients. Start from the childhood. If you build up the good muscle mass, good bone mass, good bone density at the childhood, they will carry the rest of the life. And good activities when the child plays like any sporting level, give a proper training, proper coaching, and they should not injured unnecessarily while playing the sports. That is a major risk factor. If you prevent the sports injuries in their youth or at the adolescent or at early part of the life, we can prevent the secondary arthritis. That's the one thing. Second, if unfortunately, if the patient got a secondary arthritis like rheumatoid or ankylosing, we got a very good medication. Start consulting the doctor and control that underlying disease. If you control the rheumatoid arthritis or ankylosing spondylitis, the damage to the joint will be very, very less.
Okay.
And taking a good calcium supplements, vitamin D supplements, and physical exercises. There are four types of exercises required to protect the joint. One is a range of motion. You should mobilize the each and joint fully. Range of motion that will prevent the stiffness. You know the ends of the bone are called cartilage. Cartilage, they won't get blood supply from the blood vessels. They get blood supply from the neighboring fluid. So to get the good fluid, you need to move the joint. if you have a good moments, the joint will get good nourishment and joints will become healthy. That's the
Right.
one thing. And two, strengthening of the muscles around the joint. For example, if you have a full inflated tires, the car will run easily and it won't damage. If you run the car with the low pressure tire or deflated tire, it will damage immediately. Same like that, any knee joint, hip joint, shoulder joint. If you build up the muscles very nicely, good strength, it will protect the joint.
Right.
So the physiotherapy is a very, very important from the beginning. Good, healthy, good diet, calcium rich diets, exposed to the sun, at least 30 minutes a day. That will help to keep the bone stronger. And aerobic exercises, cardiac fitness, and weight training exercises, range of motion exercises. That will help. When you get the pain, you should respect the pain, address the pain, consult the doctor. Don't overstrain your joint. That will cause the further progression. So
Right.
consult the doctor. Doctor will advise the simple painkillers to higher end of the painkillers, and it will give something like activity of daily modification activity, and give us some sprints. Suppose if arthritis on the inner side of the knee joint, they will give offloading braces so that if you walk, it won't further damage on that side. That are the strategies. My strategy is primary prevention, primordial prevention, early intervention, early diagnosis. At least we can postpone the arthritis. At
Right.
present, we don't have any medication that if you take that medication, my arthritis will stop. No, there is no medication in the world. The plenty of scientists are doing research to find out any pill that will arrest the arthritis, but not there. But our aim is postpone, as Dr. Prabhakar has told, that we have to postpone the arthritis so that the patient will have active life for a prolonged period.
Right. Thank you, Dr. Jagan, for pointing out. I think all the strategies that you have talked about are the non-pharmacological lifestyle modifications that you very nicely elaborated. Dr. Prabhakar, the rest, the pharmacological, the medical, and the surgical management strategies that we see for patients with, let's say, some advanced stages of arthritis. Let's put some light on that, please.
Yeah. See, as Dr. Jagan has already covered extensively, bone health is of immense importance. Now, when we were told when we were young, you must exercise, you must drink your milk, and so on and so forth, it was not without logic. It did had a sound scientific basis to it, because everybody tends to build up bone mass every year, and it continues to do so till he achieves a peak bone mass at the age of about 21. Now, if for whatever reason your nutrition has not been so great, or if your exercise levels have not been so good and you've not been so healthy and active, so that particular lacunae forever remains that way. Apart from that is also your genetic component as to what kind of bone stock you come from, and then subsequently your disease processes which tend to affect you throughout the life. Add to this one important factor which is relevant in today's day and age is also habits. We do tend to abuse our bodies to a very large extent, and we carry on with habits in the form of smoking or perhaps excessive alcohol intake and so on and so forth, coupled with the fact that most of us tend to be sedentary and perhaps are not so active anymore. Beyond a particular age, a certain amount of aerobic exercise, including weight training and everything else, is also supposed to be mandatory for a better bone health, because a good bone mass will come from a good muscle mass and also about the strengthening part of it. So, having said all of these, despite all these measures, if we reach a point where the arthritis is already set in, pharmacological therapy, first line, would definitely involve basic painkillers and anti-inflammatory drugs. The earlier concept of, at least in rheumatoid, used to be, start off with NSAIDs and then gradually work your way up to steroids. However, this concept has now been reversed. Now, if in case you do feel that there is a diagnosed kind of a fulminant picture wherein you have a rheumatoid arthritis or an angst person coming on, and perhaps his process is much more fulminant than what we expect, then the current therapy recommendation states that you must do something known as pulse therapy, wherein high dose of steroids are given at the first outset, and they are given as a pulse therapy wherein a high dose, you start, you stop, you start and you stop. And then subsequently you work your way up into disease modifying drugs, and anti-inflammatories are given as and when required, depending upon the degree of disability or pain at that point of time. So, however, the earlier pyramid concept, which was wherein the steroids were the last to be instituted, is now reversed, and the steroids are now the first to be used. This perhaps has helped a long way, along with the biologics, in preventing these diseases from progressing rapidly. After we reach a point wherein all of these measures, is it even if it is osteoarthritis, or if it is secondary arthritis, or if it is rheumatoid, at the end of the day, once the joint is damaged beyond a particular point, wherein the cartilage is completely gone, is eroded away, and you have bone on bone contact, along with this, there's really nowhere else to go but surgery. Now, in a case, there we differ in terms of two little things, wherein if it's a rheumatoid case, wherein you know that the joint is extensively damaged, and this is probably going to happen much, much earlier. So you do see a more extensively damaged joint in a younger individual than you would in an osteoarthritic individual. So, but then you also do tend to remember that in these cases, there is also a very large soft tissue component involvement. So, like for example, rheumatoid and all these other arthritis, they don't just damage the bone and the cartilage, they also damage the soft tissue surrounding and supporting structures, also to a large extent. So, in these cases, surgery perhaps is probably a better option to be going in for earlier. This will maintain the quality of life, it will preserve a large amount of quality in terms of what the individual can do, and it will also prevent the individual from reaching a point wherein extensive soft tissue damage and extensive cartilage and extensive bone damage is going to produce suboptimal results even after surgery. So there we have to strike a balance between perhaps intervening a little too early or perhaps too late. So that's how, that's rheumatoid arthritis. However, osteoarthritis is a little bit more forgiving animal. So in that particular case, you do tend to go in when the individual comes to us and tells us that, look, I'm having wrist pain, or I'm not even able to walk 100 meters without pain, or I'm not able to perform my activities of daily living without having to compromise on them. Now, again, this is tailor-made from person to person. For a person, maybe golfing, maybe hiking 5 kilometers is a normal requirement. It's a basic requirement for life. For somebody else, perhaps it could just be a walk to the market or walk to the park. But when we look at quality of life, it basically means that you should be able to do all the things that you want to do with your life and as a means of staying active. What is our job as clinicians is to provide as close to a normal quality of life as is feasible, whether it is through pharmacological options or whether it is through surgical options, depending upon the stage of the disease.
Correct. Thank you, Dr. Prabhakar, for very effectively answering the second half of what Dr. Jagan had started. Dr. Jagan, back to you. My question will be any recent advancements or innovative treatments that have come up in arthritic management that you recommend exploring?
Yeah, it's a very good question. The continuous research is going on to get new developments, new treatments for arthritis. One of the new treatment is orthobiologicals. Orthobiologicals is called regenerative medicine. It has entered into the orthopedics mainly for arthritis. So, what is orthobiologicals? Orthobiologicals is we are utilizing the own body cells to treat the arthritis. So, there are several things in orthobiologicals. Most commonly nowadays they are using is PRP injections, BMAC injections, stem cells, cell cultures, chondrocytes, like that they are using it. So most commonly is available nowadays is a PRP injections. What is that? Is a platelet-rich plasma. We will take our own platelet, our own blood, keep it in solution, we will spin it out, we will extract the concentrated plasma that contains a lot of platelets with the growth factors. The growth factors normally naturally we found in our body that helps to repair the tissue. It's damaged. It is a continuous process in the body. Our is a human living body. We require a lot of damage and what you call repair will be going on. But if you take that growth factors and if you give a highly concentrated growth factors in that particular area, that will stimulate the damaged cartilage into the new cartilage will be formed. Still
Right.
under trial, we don't have definite evidence is there, but equivocal evidence is available. We can try. That's the PRP injections, bone marrow cell concentrations, stem cells, mesenchymal cells, or in a damaged cartilage, what we'll do is we will take the cartilage cells, we will send to the laboratory. They will grow the cartilage sheet we will get back and we will put over the joint wherever there is a damaged part. That is called cartilage transplantation. Instead of doing a knee replacement or hip replacement, we will just put wherever is a damaged cartilage, we will put a cartilage sheet. That is a new thing. Stem cells is the thing. The other things are there are something called frequency ablations. They ablate the genicular nerves, temporarily relieve the pain. So these orthobiologicals are the new concepts and new things come in the treating of the arthritis. That's the one thing. Second thing is the surgical techniques. For a knee replacement, we have every 5 years we are getting a new knee design that will helps in a better recovery, less pain, good, less operative time, good range of movements, good flexion, quick recovery, quick walking, and longevity, and duration will be more. So it will last for 25 to 30 years. Lot of innovations, good metallurgy came. That's called metallurgy, also called tribology. This is
Okay.
good wear property, less friction, good lubrication. So the implants, new implants are coming day by day more. Better designs are coming. Better pain management techniques are available. Better surgical techniques. Very, very important is robo came into the picture. That is called robotics. It's a big milestone in this era. In India, in Hyderabad, in our hospital, we got a robot. Robo is a one of the advanced, especially if you're doing a half knee replacement, partially, Robo plays a major role. Even the knee replacements, it will give a precision cut and less blood loss, quicker recovery, less pain, less hospital stay, and higher patient satisfaction. Patient related outcomes are better. These are the recent advantages. Robo precise techniques, better implants, better what you call the metallurgy is a better surgical techniques, and better medications are available. And orthobiological. These are the new treatments available for arthritis.
Thank you, Dr. Jagan. So this was our part of the conversation. We talked about patients living with arthritis and what are. Dr. Prabhakar, my next question will be for you. What are some coping strategies that you recommend to individuals to effectively manage arthritis in their daily lives? As a clinician, please.
Yeah. See, to cope with arthritis, like I said, the initial part of the arthritic picture may not be so fulminant. That happens in maybe about 5 to 7% of the population in whom the disease tends to progress quite rapidly, and they are usually left wanting for various kind of strategies to be effective because the time factor really kind of pulls them back. However, most of the people, almost about 97% of the population, do tend to cope with these things quite well. The strategies primarily should involve, first and foremost, of course, a regular visit to the clinician so that the disease progression can be monitored and can be assessed for what it is. Secondarily, there are various disease-modifying drugs, as we already mentioned, which can be instituted at an early stage to prevent the rapid progression, even if it is coming on. Thirdly, of course, the importance of physical therapy cannot be understressed. The actual concept of having a good quality of life with regards to living with arthritis should involve a good physical therapist. There are various roles in terms of podiatrists. If there is a specific foot deformity which is already present or is coming on, that's the second part of things. Occupational therapy, if it is affecting the smaller joints of the hands and causing a lot of debilitation, can also be addressed. All of these will ensure that at least the basic functioning of the joints continues to be supple and continues to provide you with basic functions to carry on with day-to-day activities. Apart from these, the impact of this kind of disease is largely psychological. You have to understand that there's an individual who continues to feel that I am constantly in pain, I have a problem, and for which is always there in the back of his mind. So it prevents him from actually venturing out into territories which he perhaps could do if perhaps given the motivation. So yes, a large impact of it is also psychological, a good amount of counseling, and also yoga is found to be extremely helpful, both in terms of your mental wellness and also in terms of ensuring flexibility. We do tend to advise patients to look at this particular disease in a holistic proportion. So it's not just about allopathy or Ayurvedic or whatever it is, which you may want to call it. It is to be a completely holistic approach. Whatever works for you is probably what I would say to a patient. If it makes him feel happy, if it makes him feel good, and if he is able to carry on, as long as there is no side effect in terms of some medication which he does not know or which is going to cause more harm than good, I would encourage the individual to carry on with it, try it out, and perhaps it may be something which will work for him. Now, as I said, yoga is found to be an extremely invaluable tool, especially it is in maintaining flexibility, in maintaining the vital capacity of the lungs, because these are usually the complications which tend to bother and niggle as time progresses. Now, more often than not, a patient of ankylosing spondylitis is extremely burdened with respiratory illnesses which come on recurrently. That's because constantly his vital capacity continues to reduce. And this is again because a specific targeted effort with regards to breathing exercises and developing that vital capacity of the lungs has not been targeted. So now these are things which perhaps we need to address. And like I said, mobility is absolutely vital. So the individual continues to do all the things which make sure that his basic function does not get hampered, psychological well-being is maintained, and of course, it can be supported in time with physical therapy, with medication as required, and also the early institution of orthobiologics and all of these disease-modifying drugs which will delay the progression of the disease.
Right. Thank you, Dr. Prabhakar, for that well summed up answer. Dr. Jagan, in continuation to talking about someone living with arthritis, and we spoke about the coping mechanisms as described by Dr. Prabhakar, I want you to discuss about some support systems or resources that are available to help individuals with arthritis lead fulfilling lives.
Yeah, as I mentioned, this arthritis is a disabling disease. Depend upon where is the arthritis. If it is a lower limb arthritis, the mobility will decrease. So you have to give some support. They are vulnerable people. Usually elderly people will get this arthritis. So you have to modify it. That comes occupational health will come into the picture. We have to modify their stairs. If the stairs is there, we have to change the stairs. We have to give a wheelchair access commode, a toilet commode. We have to use additional booster seats. We have to give a support so that they can get away easily, or you can have a stair lift. You have a staircase, they can't go upstairs. So they usually should give change their accommodation where easily available, like a flat or where
Right.
there's no steps to go up and down. Even if it's there, give a stair lift. That's changing. Seats or sofas should be very high so that they can sit and get away from easily. And they should give a special thing. Suppose if arthritis involving the hands, like rheumatoid arthritis, where even they can't open the jar of any things, or they can't open the can, they can't open the water bottle. So in that case, you have to give a modified ones where you can have a lid one, electronic one. If you press the button, it will open it. Like
Right.
that, the change few things to be shared. It is not a single thing, it's like a group. They have to register with arthritic societies. Unfortunately, in India, in our setup, we don't have much care about the arthritis. I worked in UK for 14 years where they treat arthritis very vigorously. They have arthritis helpline. If any elderly people, they will go and register them. They will come, assess, and they will modify it, but you have to change it. Suppose if they want to drive the car or anything, if the arthritis, they can't drive the normal car, you have to give some automatic car, or you have to modify the steering, modify the seats. That will help. Suppose they go for a shopping trolley, you have to change the shopping trolley. The shopping, they can't carry any heavy bags to bring it
Right.
to home or this. You have to give a special vehicle, I think, with the wheels so that they can go in the trolley with the sitting capacity. They can, like a foldable chair, they go and sit in the chair. Like that, you have to this modification of that one.
Such wonderful suggestions, Dr. Jagan. Such wonderful suggestions. Please.
Some lot of background noise is coming in. Nishant,
I think you must be seeing some background noise. I'll be on mute while that you guys are speaking.
no. If you are mute, there is nothing is coming up.
Am I audible now?
Yeah,
Yes,
that's
yes,
fine.
yes.
Yeah, okay, yeah. Now it's fine.
Yeah, sir. Thank you for discussing such innovative solutions and these support systems that you just spoke of.
Yeah.
Before we move on to talk about prevalence of arthritis and the variations that we see in the prevalence, I'd pose a question to both of you. So we'll start with Dr. Prabhakar. The question is some common myths and misconceptions about arthritis that you as a clinician in your practice have seen and you'd like to bust through this arthritic awareness campaign that we are running, please.
See, one of the most common things, I'm sure Dr. Jagan will agree with me, is that the concept of the quality of life is very different in abroad and than what it is in India.
Yes.
Of course, having said this, this is also dependent upon a large amount of support structure which is available in India, and perhaps that leads the patients to kind of be a little bit more passive than so. Abroad, if you're not walking, there's nobody really who's going to come and do your work for you. If you don't clean your house, there's really nothing. You really can't really be doing anything else on your own. If you need to get something, you need to walk down to the supermarket, pick it up yourself, bag it perhaps yourself, and then bring it up. So they do understand the concept of being independent, and they know that that's something which is a given, which is a requirement, and they really can't escape that part. Here we have a large amount of a population which is semi-skilled or perhaps unskilled, who are available to do those odd menial jobs for you, and that tends to give that little sense of complacency, if you will, into a large population of people. The second aspect is the family support structure is certainly much more ingrained as far as India is concerned. So yes, you will find a couple of people who will spare the time to kind of look after the elderly or otherwise, depending upon how busy their schedule or otherwise is. But you'll still find that a large section of society does tend to look after, care for their elderly, and this is more purely out of sentiment and that kind of a familial structure which does exist here. Apart from this, the actual distinct concept of things when you must understand is different. The patient's mindset also says that, oh, I am now old and I really don't have to do much, and so let's not do anything. I'm happy the way I am. Fourthly, the actual problem remains because the lack of education in terms of, or awareness in terms of what are the existing therapies which you can undergo, what are the surgical options or otherwise, and what are the risks involved with this. So my take is that as and when people do tend to become more and more aware, they tend to open up their horizons mentally, and they tend to accept treatment in a better way and thereby improve their quality of life. Case in point would be knee replacement surgery.
Right.
About 20 years ago, about maybe 15 or 20 years ago, if you would say knee replacement, everybody would think of perhaps Atal Bihari Vajpayee and say, oh, that guy got it done and perhaps, the result wasn't so great. So I really should not be getting it done. But we've come a long way from those 15 years of having the implants and surgical techniques and so on and so forth. Today, there are patients who come to our OPD and literally demand that, look, I've got a neighbor or I've got a relative who's got a knee replacement done. He's walking fine. And I'm the one who's bothered with pain and I want to get it done too. It's sometimes the other way around. We are the ones who are telling them that perhaps you don't need it just now. You could perhaps wait for a while because you can be managed with other options and forms of treatment, and perhaps you can bring it up at a later date. So that change which is happening and which has happened over such a long time is the result of the awareness part which has come on, and thereby people are tending to embrace much more of the current concepts in terms of therapy. So that's something which I have noticed in my practice, that yes, things have changed. Now people do come to our OPD and ask for the latest of treatment. They ask me, what about PRP? Can I get this done for my knee? Is it going to help me? So things are much better. It's easy to talk to them. It's a better dialogue now. And yes, we can give them that these are your options, and they can make a better informed choice regarding what is it that they have.
Right. Thank you, Dr. Prabhakar. Dr. Jagan, any myth or common misconception that you have seen in your day-to-day practice that you'd like to bust, please?
As Dr. Prabhakar has mentioned, that arthritis will cause a disability, deformity, they can't do their daily activities, they can't go. Suppose if a severe arthritis of the knee, they have a deformity. So the people, if they go out, the people think that, oh, this man or this woman got deformed legs, how she's walking, and they feel inferiority complex. It is a taboo. They cannot come out of from the house. They can't mingle with the society. Still, they are not accepting. They said it's not a communicable disease, but still, especially rheumatoid arthritis, if you see their hands, it's like a devil hands. But because of that, they can't come out. They will stay at home. They can't clean. They have dirty and the smell and other things. The relatives won't come. Friends
Hmm.
won't come. They will be depressed. They will be lonely. All right of things we have to educate them. It is not a communicable disease, it's a normal things. They have to come out, and if you give a proper support, psychological support, mental health support, they can come. That is the main limitation. Not only the pain management, not only the surgical management, you have to treat globally. You have to give some psychological support, some psychiatrist help, psychologist help is required in arthritis, especially elderly people. They are depressed, they are not working, they are socially deprived. So they should give, and this concept also should be there. Arthritis along with psychosocial support.
Right, right. Thank you, Dr. Jagan, and thank you, Dr. Prabhakar, for talking about the common myths and misconceptions and how to actually solve them. Now we'll talk about some variations in the prevalences of arthritis that we see in India. So I'll start my question with Dr. Prabhakar. As we know, so that there are certain notable regional variations that we see in the prevalence of arthritis. Let's say urban versus rural, or a variation in the socio-economic zones of different populations. So I'd like to hear your views, and also how do you feel that these differences affect the healthcare delivery for the arthritic victims?
Yeah, that's an excellent question, Dr. Nishant. See, more often than not, I'm sure Dr. Jagan in his practice in the UK would have seen probably hip arthritis also in a significant number as opposed to knee arthritis. However, in the Indian population, we do tend to see more knees than hips. Again, unless it's a post-traumatic situation. Now, a large amount of this can be attributed to our
Uh,
cultural practices.
Sir, we just lost your back. Please
Yeah. Um,
continue. Please
Am I
continue.
audible? Yeah. So, I mean, a large amount of our arthritic picture in terms of, knee is predominantly much more affected. And of course, the hip is perhaps less so as opposed to the Western population as per the literature and so on. Now, this is can be largely attributed to our social as well as our cultural practices, wherein we do tend to have much more increased functions in terms of squatting, sitting cross-legged, because almost all formal functions in terms of either religious or otherwise, we do tend to have a large population which tends to sit cross-legged or perhaps squats or otherwise. Now, this particular option of squatting or otherwise does tend to be a little bit more in the rural population, wherein they do tend to use much more of the Indian style this thing for their ablutions, and perhaps more of a Western style towards the cities and more urbanized areas. This does tend to put more amount of pressure across the knee joint, and we do tend to see a marginal higher percentage of degenerative arthritis on that side. Now, when we look at this, it also involves the treatment protocol, because the functions and the requirements of the population also happen to be different. For example, if it's a farmer or if it's a gentleman living in a rural setup, now he probably may not have access to a Western style commode of sorts. And then for his personal toileting and so on and so forth, he either has to take a modification into wherever he's living already, or he wants those functions of squatting and sitting cross-legged because perhaps it is not so culturally acceptable in the region he lives in or in that particular socioeconomic strata where he moves around in. This perhaps may not be so much of an issue in an urbanized individual, probably an office going worker of some sort, and wherein he can pretty much modify his lifestyle according to his requirements. And he may probably never need to really squat, and he can get away with it probably throughout the rest of his life without really having to do so. So, there we do tend to tailor make treatment in terms of what is it that the individual's requirement are. Secondarily, what is it that the implants and the condition, which kind of gives us that little bit of a latitude to do so. So we do have younger individuals more severely affected. As Dr. Jagan said, there are extremely important advancements as far as the joint replacement surgery is concerned. You have lovely implants which gives you that options of squatting, sitting cross-legged. Now you have a newer kind of an approach to the hip joint, which is the called the direct anterior approach, in which we just take the incision anteriorly where the posterior capsule is absolutely undisturbed. So we can encourage, even with the standard hip implant, we can encourage individuals to squat, sit cross-legged from as early as 2 to 3 weeks. And they've had excellent results. So as we continue to evolve, we are able to cater to what is it that the basic requirement of the individual is. But having said that, it is still a tailor-made kind of a solution, we do tend to see what is it that the individual needs depending upon his occupation, his socioeconomic status, his requirements. And then we fashion it as to what is the best option perhaps for him.
Right, right. Thank you, Dr. Prabhakar, for that wonderful answer. Dr. Jagan, my next question will be for you. As we have understood through all these panels, through all this awareness about arthritis, that it requires a very multidisciplinary, very tailor-made, holistic approach for
Yes.
every arthritic patient. Can you comment on how healthcare providers and communities can work together to improve the arthritic care at the grassroots level, at the starting level, please?
Yes. In India, we got a very good health system. Like in rural areas, we have a PHC, that is a primary health care center. We got community health care center workers, multipurpose health workers, ASHA workers. There are so many workers are there. At present, they are doing different things like child education, vaccine program, or family planning program, like that. Immunization program is there. They have dedicated multi-purpose health workers. At present, there are no healthcare worker for arthritis. So what we need to do is we need to work it out at the national level. National level health system like a health ministry has to involve the put a some task force and involving the existing workforce. As we have a health economics limited budget, we can't create additional force, additional health workers to tackle only arthritis. No, it is not possible literally. So what we need to do is existing staff, they should train them, identify them, how to identify the arthritic people, what best they can do. They can do a lot, like they can support at the community level, like rheumatoid arthritic patients. Even they can't take the tablets because of the hand problem. They can't eat, they will have the nutritional problem. In that case, the healthcare worker or support worker, they can go, they can give promptly medication. If it is anything, they can bring the patient to the tertiary center or the community health hospital, so that the surgeon or the orthopedic surgeon or rehab surgeon, they will treat it, they can get back the hand, they can do it. That's the one thing. Community health worker support is very important. The physiotherapy play a major role in arthritis and medication. Pharmacies should be supplied at doorstep.
Mm-hmm.
Some arthritic medication like rheumatoid arthritis, as Dr. Prabhakar has mentioned, that biologicals are very expensive. The government should interfere and they should give a free to the patient, especially poor patients. They should give a free and it should be delivered at the door level. So the pharmacist can play a role, physiotherapists can play a role, multipurpose health workers, support workers, ASHA workers, they play a major role in supporting the arthritis. And arthritic clinics in the Western society, we have arthritic clinics like rheumatoid clinics and other things. Here also, in government hospitals, the one wing, at least weekly, twice or weekly once, they should start specialty clinics like arthritis clinics. It is medicine, general medicine, rheumatologists, orthopedic surgeons will have a combined clinic. They will do a combined clinic. That is also comes under what you call multidisciplinary
Right.
approach or community work.
Right. Very nice, innovative strategy, Dr. Jagan.
Yes.
Dr. Prabhakar, in continuation to Dr. Jagan's answer, any governmental or non-governmental organization that you are aware of which is raising awareness and providing support for arthritic patients that you'd like to tell to our viewers?
Yeah, to the best of my knowledge, governmental wise, I really don't think there's much data which is available in the public space to begin with. There have been a few papers which have studied the prevalence of arthritis across the Indian population, and the disease prevalence in terms of arthritis ranges anywhere between 22 to about 39% as per a couple of papers. However, we still do tend to lack a basic, very robust kind of an infrastructure, including NGOs, because as Dr. Jagan rightly said, a large amount of it is associated with that little stigmatization of things, and patients do tend to kind of stay away from the common population and do tend to kind of just remain within the boundaries of their households. But the first part, of course, is the education. People do tend to understand that yes, it is not a communicable disease and perhaps they don't need to be ostracized for it. But this awareness does need to go a long way. As Dr. Jagan said, yes, the approach has to be multidisciplinary. And we at present don't really have an existing kind of a situation wherein we have 3 or 4 specialists sitting together and we have specialty clinics running in India. At least I'm not aware of those. NGOs do tend to support the various forms of people with disabilities. However, specifically for patients in terms of arthritis, it's not so. But yes, the NGOs, there are several NGOs are working across the spectrum who do tend to kind of tend to these people with disabilities and do tend to help them with whatever it is that they need. If in case somebody who's perhaps wheelchair bound, they do tend to make sure that he gets his medication on time and he gets a replacement wheelchair in case one is damaged or defective, perhaps a motorized one if in case the disability or the degree of disability is very, very high. So these are some things which do institute. However, there is a lack of a concerted and a focused approach in terms of multiple NGOs and the government coming together and providing an adequate amount of care at the tertiary.
Thank you, Dr. Prabhakar, for that. So, moving over to the last segment of our conversation here, we will be talking about what preventive measures can individuals take to, let's say, maybe avoid the risk of developing arthritis or progressing arthritis. I know both of you have covered a lot of these topics, so we'll have it summed up here. Dr. Jagan, I'll start with you, please.
Yeah, the preventive measures already we have discussed. Start from the childhood, good talk, protection, prevention of the sports injuries, healthy lifestyle, good diet, calcium-rich food. Maintain the body weight is very very important. They should know about what is arthritis from the childhood. Where if might need damage now at the age of 15, lifelong I have to suffer. That education should come from the childhood. They should involve in the science subject during the childhood, like 8th, 9th, 10th, or from the beginning. This also should be a part of the science curriculum in the schooling. They should aware about this arthritis and other things. What is the importance of maintaining the bone health? What is the importance of regular exercises, weight maintenance, and sports injury prevention? That will be very very important. Once they got arthritis, seek immediately, respect the pain, consult the doctor, following the advice of the doctor. If they got secondary arthritis, you control the disease, don't miss the medication, and if it is there, you seek the higher specialist for the good relief. That is the thing. The one thing is primary prevention and primordial prevention. These are the very very important for preventive measures. Any public initiatives, awareness programs, the government and NGOs, it is difficult in this huge population, government to do all the things. But NGOs should be more and more NGOs should come. Arthritis Society, arthritis prevention, regional arthritis like that, or the pharma companies or implant companies, they should encourage the NGOs to conduct camps at local levels, village levels, mandal levels, district levels, and they should have a club like orthopaedic clubs. They should conduct monthly meetings, monthly runs like 5K walk, 10K walk, or cycling walk, or triathlon, something like that, and encourage it. Like conducting at community halls, should conduct some educational programs like giving expert talks, PowerPoint presentations, or they can do a mass physiotherapy classes like Jumo classes or movement of that some fun day. It's a knee day for the September week or something like that. They come, all the group in that society will come. They interact with them. They share their experiences and involvement of the community one by one. I think that will helps in better prevention rather than
Thank you. Thank
focusing
you.
on individual things.
Thank you, Dr. Jagan, for very nicely summing up. Dr. Prabhakar, if there is anything that you'd like to add,
Absolutely. Thank you, Dr. Jagan, for making my job easy. I think he's covered all the things. And to reiterate just the preventive aspect of it, when we talk about secondary arthritis, at least in India, a large chunk of it is owed to road traffic accidents, leading to severe injuries and subsequently arthritis development. My this thing would only be just to add on to what Dr. Jagan has already said, the adherence to traffic rules, the importance of road safety, and trying to impress this upon the individuals from an early age would go a long way as far as the prevention of these things is concerned. See, once a joint is damaged, even if it's the most gifted surgeon on the planet, and I could put it probably back together or otherwise, and perhaps anybody else could, but you do have to understand that it's never going to be as pristine as it was earlier. So you are looking at a situation wherein you are a bit decompensated, and it is going to lead to an early wear. May not be in 5 years, may not be in 10, but perhaps certainly in 15 or 20. So you are looking at something which is going to hamper your quality of life, which is largely preventable. Now, all that you need to understand is the education factor in terms of prevention, which is adherence to the traffic rules, and certainly other habits and everything else which can be toned down in terms of voluntarily trying to do things like, for example, alcohol intake, your sedentary activities, your smoking, and so on and so forth. Now, these are things which are preventable. Of course, if there is a genetic component and somebody who's already got a tendency for it, there's not much which you can do. But these are things which can be prevented and should be done so.
Thank you, Dr. Prabhakar. So with this, I'd like to bring this panel of discussion on arthritic awareness to a closure. I'd like to thank all the viewers. I'd like to thank Pfizer for powering this, and I'd like to thank my esteemed speakers, Dr. Jagan, Dr. Prabhakar, for stepping up, taking time out of your busy OPDs and schedules in taking this step. We really appreciate. And one last key take-home message, one-liner from both of you. Dr. Jagan, we'll start with you.
Arthritis is not a communicable disease. It is a disabling disease, one of the most common disease. If you take a prevalence, more than 40% will have arthritis in 60 plus age group. Women are more prone for arthritis, so they should care themselves. You have to invest your own time on your own health. Nobody will look after you. You have to look after yourself. So that's very, very important. My motto is you have to look after yourself, sir. That is the thing, especially health wise. Nobody will look after you. Your wife, father, mother, kids, nobody. It is your responsibility to check your health.
Right.
That's
Thank you.
simple.
Thank you. Thank you, Dr. Jagan. Dr. Prabhakar, your one-liner take-home message for all the viewers who have engaged with us.
I'm going to borrow this from Dr. Jagan, and the American Association of Orthopedic Surgeons says movement is life and life is movement. So that's absolutely there. And so absolutely one needs to understand that the quality of life is important. We need to preserve it. And for every individual, whatever it is that he wants to do, he should be able to do it. And we should be in a position to give him that quality of life which he wants to achieve.
Thank you to Dr. Jagan. Thank you, Dr. Prabhakar, for stepping up. Have a good day. I will bring this session to a closure now. Thank you.
Thank you, Dr. Nishant.
Thank you
Thank you, Dr. Jagan. Bye-bye.
Thank you, Prabhakar, sir.